I will give the floor to our director, Alexis Goosdeel, for the opening remark to this webinar on drug consumption rooms. Thank you.
Thank you, Marika. Can you hear me?
Yes, perfectly.
Yeah, so hello, everyone. I'm very, very delighted to welcome you for this new webinar of the EMCDDA. I think slowly but surely this will become one of the last webinars of EMCDDA until we become the EUDA, the European Drugs Agency. And certainly you will see that this will even strengthen further our commitment to support practitioners, people from the field, but also decision makers at the EU level and in the member states. And I think the topic of today, the drug consumption rooms, it's a very important one. I think it comes at a very crucial moment because drug situation is changing the recent years in the EU. Of course, there is a big issue related to the huge availability of cocaine. 2 years ago, 330 tons of cocaine have been seized in the EU. But we cannot forget that the drug problem in the EU is not only about cocaine. It's a problem of various substances use and abuse that entail new risk behaviors and new potential harms. And therefore, but the second problem we observe in the EU, increasingly also, unfortunately, is drug-related violence. And those two elements, they have consequences, both in terms of analysis of the needs, what are the problems, what are the risk behaviors, what are the needs for new responses, but also the emerging drug-related violence problem is also calling for different way to look at the different responses. What is our toolbox? And part of the toolbox will need to change in the coming years, just because as the substances have changed, some of the routes of use have been changing. Definitely the old European model based on the heroin epidemic and for which substitution treatment have been extremely efficient among other responses. Today, the situation is more complex. We cannot just repeat some of the solutions that we had already a lot of difficulties to apply and to agree upon in the last 30 years. And at the same time, I have the feeling that we are at a moment of great danger for many of the harm reduction services and programs because of the wrong expectations there may be regarding what are the expected results, what are the models. So on the one hand, we certainly need to include in our analysis everything that is related to violence, but not only criminality, and therefore as one of the first initiatives of the new European Union Drugs Agency, we are going to organize a conference on drug-related violence end of November, and this will take place in Brussels. And then coming back to the specific topic of this webinar, we continue to support the scientific work, the methodological work regarding the various models of drug consumption rooms. And all those different models, they can take a place in the portfolio of responses. So let's be clear, I will not tell you in advance what are the conclusions, because I'm really keen and very happy we have so good guests and speakers today. But certainly we need to be careful that we don't pretend that drug consumption rooms on their own could or should solve all the problems related to substance use. That would be the best way to kill all of them so easily, and that would destroy a huge benefit, not only for people who are using drugs, but for the other citizens, because it's not a question to make a distinction between citizens and non-citizens or sub-citizens. We are all the same quality of citizens, and this is part of the EU model that we need and we want to preserve. But clearly, we need to integrate our understanding of what could be the added value, the benefit of having a DCR. It has to be part of what we call sometimes a harm reduction system, and not only one kind of service. And to speak about this today, we have a wonderful chair, and in 1 minute I will be extremely pleased to hand over to Marie. We have fantastic speakers working with incredible organizations all over Europe. I had the privilege to visit already some of them, or to have with some of them, like Viktor, we have a very long time cooperation together. My last word before to give the floor to Marie and to listen to you and to join and to share some reflections at the end is I want to thank especially Marika and the EMCDDA colleagues because we managed in the middle of the pandemic to launch our first EMCDDA webinars. Can you believe that we have already more than 30 of them? And one of the key things for us and for me as director is that it's not EMCDDA pretending to know it all and to tell it all to everyone. It's EMCDDA to offer the platform for the experts, for the actors from the field, to share their experience, to share their know-how, and to help us better understand, of course, using also scientific and evidence-based information to understand better either problems or responses. And today, I think it will give us a very interesting panorama of what are the different added values, what are the different public values of DCRs, provided that they are built and developed and designed, taking into account the relevant and specific local context. So again, thank you all, and I look forward to a very exciting webinar, like every time today.
Thank you very much, Alexis. Thank you also for recognizing the role of all the colleagues. This is a transversal effort, including ICT, communication unit, our trainees, Mette, at her first webinar. Thank you very much. And as you said before, I will give the floor to Marie Jauffret-Roustide, Principal Investigator at INSERM and member of our scientific committee. Marie, the floor is yours.
So thank you, Marika. Thank you, Alexis. So first of all, I'm very honored and pleased to be the chair of this fantastic webinar today, because for me, harm reduction policy is very crucial in drug policy. And as Alexis just said, that's a very perfect moment to speak about drug policy, drug consumption rooms, because we have a lot of scientific literature that have proven the efficiency of drug consumption rooms, but at the same time, drug consumption rooms have also to face some challenges with some political resistance in some countries. So that's a perfect time to speak about this topic, and I thank all the EMCDDA team and especially Marika, Isia, Alexis, and Met for having implementing this webinar today. So I will now present our fantastic team of panelists today. So our first panelist will be Roberto Perez Gayo. And Roberto is a social designer, activist, and researcher. They are the coordinator of the European Network of Drug Consumption Rooms and the head of policy at Correlation Network in Amsterdam in the Netherlands. We will, after the presentation of Roberto, have a fantastic panelist team with Ester Aranda Rodriguez. She's the director of harm reduction at the Asociación Bienestar y Desarrollo. And she's also a researcher in UNAID, Addiction Network. She managed a drug consumption room in Barcelona, in Spain. And we will also have with us Viktor Mravčík. He's a medical doctor and a research director at the NGO Společnost Podane Ruce in Brno. Czech Republic. His NGO recently opens a DCR, and that's the first one in Czech Republic. And our last panelist will be Marylin Pohler. She's a social worker at Ragazza, a lost resort center and shelter for women who use drugs, based in Hamburg in Germany. So, Roberto, I will give you the floor for your presentation. So you will presentation in your presentation will last 5 minutes, and you will present different model of DCR, a work that you did for EMCDDA. And before opening the floor, I would also I will also thank very warmly EMCDDA for all the involvement that the agency has on drug consumption rooms. So Roberto.
Thank you very much, Marie. And also I really would like to thank Marika, Alexis, ECR, which is not in the camera, and all the colleagues of the EMCDDA that we have this beautiful working relationship, and also like for inviting and to present today. With my presentation, what I would like to do is a very quick look into current practices and future scenarios on drug consumption rooms. Can I? Yes, I think I can do it already. I can control, yes. In here, I'm showing you the most current map of drug consumption rooms in Europe. This is a census that we did together with all the drug consumption rooms on the ENDCR. And at the moment, we are counting with 101 drug consumption rooms implemented in Europe. Luckily, this number is going to be increasing because in the summer, we are going to see drug consumption rooms opening in Ireland, also in the UK, also in Slovenia. So we see that within this increase, the number and availability is being upscaled. But also what we see is that over the recent decades, especially if we compare when the moment that DCRs are starting to be opening for almost 4 decades ago, drug consumption rooms has been starting to establish a whole series of changes in their operation and in the functioning that are adapting also to the changes in the profiles of the people they're working with, on the needs of these communities, on the patterns of use, on the substances, but also with different shiftings in the markets, in the social conditions and the structural factors, in a way of trying to increase the protection and the safety of the people that they are working with them. Things that we are seeing, and it's important to look within the models and the DCRs that they're happening, the changes. Sometimes these changes that we are seeing has been happening on the level of the service or what services has been done, especially compared. We see there has been a big expansion to the routes of administration and substances compared, as Alexis was saying, with the first DCRs that they were responding to opioids and also to injecting as the route of administration. We see an increase of drug consumption rooms offering a space for smoking. Also, we see a major presence as well of stimulants. For example, maybe Ester later on is going to be referring a tiny bit of methamphetamine, or even though, for example, in the Netherlands, we are starting to see GHB within drug consumption rooms. And all of this is generating different strategies and forms and ways of doing that. Could we go to the previous slide, please? I think I cannot control it now. Yes. Also, another part that I'm going to be highlighting very briefly is also like the implementation, the integration of drug checking services within drug consumption rooms as one of the most innovative elements that is happening at the moment, not only to increase the safety and the protection of the communities they're working with, but also as another element that drug consumption rooms are having as a more prominent role in the monitoring, in the research of the drug markets that are happening. Also, other elements that we see is an increased sexual and reproductive services, labor integration, and we are also seeing, for example, housing responses. Also, what we see is that the drug consumption rooms, whereas back on the day, they were targeting to a profile that had to do much more with a male, cis, injecting heroin drug users, are responding at the moment to a diversity of target groups. In the picture, for example, I'm showing here medicineres, but probably our colleagues of Ragazza that presents later, they're going to give an example of how a drug consumption room can be targeting and responding to the needs of women, gender non-binary people, and trans people. Also, we are seeing that other ones are responding to mental health, and I will show you an example of a drug consumption room locating within a mental health facility. And at the same time, also, we are seeing that there is other series of factors like homelessness that actually are starting to take much more factoring into consideration. The next part that we're seeing is also like it changed very much to increase the access and the quality of the drug consumption groups into how the services has been provided or are provided. We see an increase of multidisciplinary teams in which integrated services is happening by the combination of health, social professional, and also community members being in there. We also see an increase, we would like to see more, but we see an increase of peer workers, people with the lived experience developing, evaluating, and also providing the services in the drug consumption rooms. And more importantly, we are seeing big changes and adaptations to the operational procedures and rules. Questions, for example, with opening times, but not only that, also questions like assisted injection, which is something that back on the day in many drug consumption rooms could not take place. At the moment, it's something that is considered in many as a way of also, for example, increasing the accessibility of women to drug consumption rooms. Or we see how also drug consumption rooms are developing new pragmatic law enforcement strategies. For example, in Switzerland, in which there is areas of micro dealing that they are tolerating within the drug consumption rooms, not only to reduce public order problems, but also to increase the safety of the users. Lastly, also what we see is that there are a lot of different changes into the settings in which these services are taking place. The example that I'm putting in here is one that is actually really beautiful. This is Woodstock. Woodstock is an elderly care home that is providing services for all the drug users. It is quite unique. Oftentimes, we are also forgetting that drug users, when services go well, also like are aging. So this is an example of something that is very innovative. Another examples includes also accommodation or more residential spaces. Probably Ester will speak about that. Also, we see that actually places in which only one drug consumption room took place are starting to increase more. This is the case of Denmark, in which at the moment they're starting to look in Copenhagen how to increase smaller numbers, or sometimes complementing, like, well, it's going to be the case in Athens, to have a fixed room that is going to be complemented by several mobile ones. And this also has to do with the fact of taking a tiny bit of a pressure of having only one certain and expecting that this center will be the only one that is able to provide solution for all the drug problems that exist in an area. Traditionally, drug consumption rooms all across the literature, feasibility studies has been understood in three different types of models. Integrated, in which a whole array of services are provided next to the supervised consumption of substances. Specialized, in which is focusing normally in high traffic use places to provide barely these services, which is safety materials. And then we have mobile services coming around. However, as Alexis was also mentioning before, drug consumption rooms do not work on isolation, and the success of drug consumption rooms also passes by being integrated within other network programs of care and support that exist in the city. And even in places like specialized drug consumption rooms, we see that there is integration of how the social and medical services, and oftentimes the mobile drug consumption rooms are part of an integrated service within a larger. So this distinction between integration, we see that already exists across all of these different models and doesn't give us a very clear picture of actually what is the situation at the moment with drug consumption rooms. In the work that we are doing at the moment in correlation with the European Network of Drug Consumption Rooms, together with our members, we are starting to shift it a bit. And in our case, we are starting to be looking and focusing much more into place, into location, into the setting, because this allows us to understand not only the complexity of a variety of drug consumption room models that exist, but also offers us a bit of a lens of imagination to develop what else can be happening, departing from local level, the knowledge of the communities, the leadership of the communities, and as well understanding that oftentimes attending to the health disparities of the communities oftentimes passes by highlighting and responding to the structural factors of vulnerability that these communities are having, and tailoring programs that are able to respond to this context and to these specific needs. So from here, as you can see, in the moment that we take a lens of place, we have an increasing much more variety of drug consumption rooms that exist in here. What I'm presenting you is documented models that we have been collecting. And then we have from urban setting is not only vans and mobiles DCRs, especially if we look it through the scale of the world, not just Europe. Then we see tents and overdose prevention centers, PA injection support programs, low threshold facilities in community centers. We have seen drug consumption rooms in workplaces, in community pharmacies. There is a big increase of drug consumption rooms in residential settings, emergency shelters, housing first programs, elderly care homes. Another one that I would like to highlight is how we are starting to see supervised consumption starting to happen much more in healthcare facilities, primary care centers, OAT centers, HIV centers, mental health care, in prison and non-enclosed settings, and also in other informal, remote spaces. So with this, we are seeing that care and health not necessarily is exclusive to a particular setting, but we can be a start to look. Drug consumption rooms allows the opportunity to be looking into specific places, identify factors of protection, and understand how to respond to the structural conditions that they are creating vulnerability for people who use drugs and they are contributing to overdoses. We see how many also, for example, in the case of integration of drug consumption rooms of services of general population, are looking much more into the well-being in a holistic way for people who use drugs. And more importantly, they're also putting forward the capacities of communities to respond on a local level, building not only on those knowledges, places, and resources, but also on the leadership of the community itself to provide this. And I will leave it in here.
Thank you, Roberto, for this very interesting presentation. I think that what we have to keep in mind, it's very important what Alexis said at the beginning of our webinar. It is the fact that we need to have to be careful and to avoid misunderstandings about drug consumption room. They can't solve all the topics related to drug use, but it's also very important to have a diversity of services around drug consumption room. And it's very interesting with your presentation to see how drug consumption room can also, even if they don't solve all things, they also have evolved a lot and address a lot of topics related to drug use, such as social inclusion, and that's also very important not to envision drug consumption room only with the public health or public security approach, but also with social inclusion. So we will now move to the first question of our webinar. So the first question will be, while planning the implementation of your drug consumption room, what role or reference models did you take into account, and were you informed or influenced by international experiences? We have also to say that, to remember that the first drug consumption room was implemented in Bern in 1986, so it was a long time ago. So we have now a lot of international experience that can inform or influence the implementation of the new ones. And how did these experiences inform your decisions and planning? So I will give the floor to Ester first.
Okay, hello everybody. Okay, I think to respond to this question, it's well, I think to context everybody, no? Since 2004, Barcelona has DCR for injection route, and since 2009, I think also for inhaled route. In this moment, no, Barcelona have a very big network of consumption rooms and treatment services. This network is from Public Health Agency, and I work in ABD, that it's an organization who manage this kind of DCRs. Well, I think we have lived 4 waves of DCRs in Barcelona. The first one was at the beginning, and I think our reference model was maybe Switzerland and maybe Canada, but they are countries very different as our characteristics of Mediterranean flow. So okay, we can reproduce some programs like the typical needle exchange, consumption rooms, or overdose prevention, or the outreach team, but we are very different in terms of cultural aspects. So not everything can be replied when you are adapting or you are implementing a DCR. In the second wave, we were in another situation, because we opened the first inhaled consumption room in the city, and in this moment we had the DCR, but we didn't have the people who to use the DCRs. So we had to implement strategies to arrive to the people, and we have to design materials to arrive and to put in the DCR. It was another situation, and of course we didn't have models. In the third wave, it was related with the COVID, so models, time, literature, or the typical methodology to implement a service or program, it doesn't possible. And I think it was a very interesting experience, because at that time, all the city shelters were characterized by the typical rigid access hours, no access for people showing signs of intoxication, and the detection of paraphernalia or consumption inside was a reason for expulsion. So in an emergency moment, we designed a shelter with a harm reduction approach, but trying to lock down people and also to not reproduce all the mistakes that we were detecting in the other networks, no? So I think it's important in this kind of spaces that harm reduction shelter is not only a DCR with beds. That's everybody think, no? When you say it's a shelter with harm reduction, okay, no? You put beds over the DCR. No, it's not exactly this point, because you have to change the approach, because in a typical DCR, you put the substance use in the center. And when you are talking about an integral or integrated model with a response to homelessness and to harm reduction substance use related, you have to move the center, and you have to put in the center the person. And in the first time, in the first moment, you have to guarantee the roof, and after that, okay, we are going to talk about substance use. The results were very good about this experience, and the implementation of this shelter changed, I think, the harm reduction approach in Barcelona, because we no longer view the people who use drugs, only as people who use very risky administration routes and substances. Now we view people who use drugs as people who had lived on the streets for a long time and had used substances to survive in this context. I think it's a change in a view of harm reduction in terms of DCRs. And of course, it's important because homelessness network in Barcelona know that this shelter is essential, but also the harm reduction network in Barcelona knows that this shelter is an essential. So both networks are working together, and it's very, very important. Also, it's okay. Yeah, I think it's okay. Yeah.
Thank you so much, Esther. So you point out a very important topic in your talk that that is often not very highlighted, is the topic of social inclusion. So that's very important also to envision drug consumption rooms are as protective refuge for people who use drugs, who are always stigmatized, and that's also something very important. So thank you. So I will now give the floor to Viktor. Viktor, you implemented with your team the first drug consumption room in Czech Republic. Could you give us some elements about the implementation?
Yeah, thank you, Maria. As you said, our drug consumption room in Brno, it's mobile drug consumption, is the first in Czech Republic, and so far the last one. It should be mentioned that we try to open drug consumption room in Czech Republic in the last 30 years. So it's been already 30 years we are trying that, and finally it happened in Brno. It was already mentioned that it's rather those national circumstances, national policy, national legislation, and local circumstances and factors which shape the design of the concrete drug consumption room than other way around. Yeah, so, but we will talk about that in the next part of our webinar about these local factors and all different factors. But beside that, of course, evidence about how drug consumption rooms are designed, how they work, what are the outcomes, experience from other colleagues are very important for those who are trying to start this novel kind of program. Yeah? So it was important also for us. And here I would like to acknowledge all the work of the network of drug consumption room and also all the work of EMCDDA. I mean, promoting the harm reduction measures and drug consumption room, and Dagmar Hedrick should be acknowledged here, right? So we use all the resources to promote the concept in Czech Republic all over the years. And in this final steps in Brno, and again we will talk about that in the next part of the session, we were inspired especially by the model from Lisbon. I saw Hugo Faria present here in this webinar. So again, big thanks to colleagues in Lisbon. So our part or people from our team visited the drug consumption room there. And also very important for us was the concept in Berlin. Yeah, first, Germany is close to Czech Republic. The systems are similar, not only in drug policy. Germany is a kind of reference for the Czech Republic. And Berlin has a stationary and mobile drug consumption rooms. So we visited them in Berlin, and especially this mobile one was the big inspiration with all the details for us in Brno. Yeah, in this last phase of preparation in Brno. So and about all the local specificities and factors we will talk later, right? So that's for now.
So thank you, Viktor. Yes, you highlighted the topic of alliances between local and national level, and we know that there are sometimes a lot of resistance, political resistance for implementing drug consumption rooms, and yes, these alliances are crucial, and the international cooperation is also very important, and that's why that's so important also to have this webinar to be able to speak about all the experiences. So I will now give the floor to Marylin. So Marylin, Germany plays an historical role and is a very important player for drug consumption room implementation. So could you speak about what happened in Hamburg?
Yeah, thanks, Marie. Yeah, so Ragazza, the consumption room in Ragazza was established in the year 2000. And so at that time, Ragazza was already existing since 1991. So originally it was a kind of street work project for the sex workers here in the kind of illegal red light district, doing mobile outreach work, having a kind of regular stable, yeah, stuff like that in the very beginning. And so Ragazza was growing step by step. Started with a really small flat, or rather a small room where everything took place. And so the offerings and the services grew. And in 2000, when the consumption room was established, there was already experience with consumption rooms in Hamburg since the middle of the 90s. So there had been several consumption rooms in Hamburg, for example, a mobile consumer space, integrated consumption rooms like Abrigado, drop-in, like the big and old institutions, and even exit-orientated consumption rooms that were docked to counseling centers. So there have been things being tried out. And so in Hamburg, there was, in the middle of the 90s, a strong movement in, because like, committed employees and initiatives in the field of addiction support have been fighting for progressive models. And the role models, of course, have been Switzerland, Amsterdam. And their commitment worked. And so together with Frankfurt, the first consumption rooms in Germany were created in Hamburg. And so there was already experience and good networking and a dialogue among the colleagues at that time, because everything was located in the same city. So it was, very nearby. And the model of the consumption room, because Ragazza already existed before, and it was fixed to the location, to St. Georg, the main station district, and where the drug scene was and where the sex working was going on. It was clear that the consumption room has to be integrated in the institution, which was already existing. And but also in all these years, of course, like things have been tried out. Like there have been, there was a mobile space, a mobile service in the 90s for about 15 years, but without the possibility of consumption, but just for needle exchange, medical care, counseling, and so on. And of course, while establishing the consumption room for drug using women at that time was quite unique. So there haven't been many references at that time. And also the local aspect's very important, but we will see in the next question.
So thank you to highlight the topic of gender-specific services. That's also very important, because we see that often women are not very visible in drug consumption room, because they have also, and in harm reduction services, because they have to face a lot of violence, and that's why sometimes they avoid to be in contact with models that welcome a lot of men, and that's very important to have gender-specific models. So we will now move to the second question, and the second question is more about environment, because to have effective drug consumption rooms that will be effective, that's also very important to have drug consumption rooms that are adapted to the specificity of social, cultural, and economic environment. So our second question will be, what are the local aspects that influence the selection of a specific model of drug consumption room in your case, and how were local determinants incorporated in your plans and development? So I will give the floor to Marylin to begin.
Okay, so the local aspect for the institution Ragazza is very important, because Ragazza is very close to the scene and to the target group. It's located in the main station district. It's a not legal red light district, estimated for about 150 years. It's took place here. In the 80s, it was like the drug scene was there, and it was quite big, and still is quite big. So it was always clear that Ragazza makes sense at this place, near up to 80% of female consumers financed through sex work. So the proportion of women in the scene is around in Hamburg, around 30% of women in the scene with a high multiple risky drug use. So poverty, marginalization, criminalization, everything was going on here, because doing the sex work, the women are criminalized here in a double way, and because of the sex work and the drug use. And so it was obvious that Ragazza makes sense at that place. And yeah, and there had been plans from the authorities to create decentral consumption rooms to avoid a pull effect into the quarter, what was already quite, like a big drug scene, and the public and the residents were already, nervous. And Ragazza could always defend the location here at this place because the scene is not very mobile. The women are here at this place. They come in, do what they want. They go out. So they use us during the opening hours. More times, so it makes sense that we are so nearby. Yeah, that's it, I guess.
Thank you, Marylin. I will now move to Ester. So, Ester, which model did you choose in Spain?
Oh, I know. When we are thinking in harm reduction terms in Spain, we have to know that the situation is very different between regions, and I can talk about only from Barcelona, but I think if we are thinking in the local situation in harm reductions in Barcelona, we have to talk about homelessness, we have to talk about violence, and we have to talk about the cooperation between administration and the community organizations. I think if we put these three elements on the table, we can understand, and we can understand how to move to do a good response all the time. I think it's very important that Catalonia and Barcelona have been characterized by applying the social determinants of health model. So it's very easy to add harm reduction in this model. So the local response are always in this mood. Fortunately, the city have an strategic drug plan of drugs. A strategic plan estratégico strategic drug plan who includes specific attention for substance users and homelessness. So some responses are easy to implement thanks to this plan. With the photo, under our experience in the DCRs, we knew that we had another issue to resolve, and it was the gender violence inside the harm reduction centers. So this aspect were very important. Talking about when you are talking about a mixed shelter, together with a very expert professional in gender, we analyzed in depth the usual dynamics that we had experienced during our professional career in harm reduction services. Elements such as the need to implement a non-mixed spaces, staff and PUET have to consense what is violence. This question, I think it's essential to respond if you want to adapt the intervention. Also, we have to position policy against sexism, LGTB phobia, racism. These points have to be inside the DCR. Also, you need money to responses in terms of violence. And in our experience, it was essential to create a specific budget for gender-related issues inside the services. Also, the external supervision, it was important, and the continuous training in gender, But I think there is another point very interesting in this service when you are thinking in our local view. It's according to the legal status of the substance, because in Spain it's very classical, the view of, and I think it's also common in other countries, that we separate harm reduction in alcohol, which is legal, and the other substances that are illegal. And this shelter mix all the substances. We offer a DCR from injection for inhaled, but also for oral use. So people inside that doesn't be separated by the legal status of the substance. That it's gonna be across discrimination if you are separating. Also, we tried and we are doing the first alcohol maintenance program. It works in the same way as methadone program, and I think it's another different point in our local harm reduction approach now.
So thank you, Esther. Before giving the floor to Viktor, I want also to stress an important point, because I saw a discussion in the chat about rehabilitation. And I think that it's important also to introduce here that drug consumption rooms are designed to respond to urgent needs of people who use drugs, and especially to give them space to inject in more hygienic spaces, and to avoid also to inject in public space. And that's why also drug consumption rooms are important for public health and also public security. But drug consumption rooms are also spaces where people can have contact with harm reduction professionals. And that's why that's also a way to facilitate rehabilitation for people who use drugs. So I think that's very important, not to oppose social rehabilitation and harm reduction. They are very intertwined, and and I think that all the people who are working in the field of harm reduction and who are implementing drug consumption room have this in mind, and also try to work for the social inclusion for people who use drugs, but adapting to their needs, what they need at a moment. And rehabilitation and abstinence, for example, can also be needs for people who use drugs, but that will happen after a first contact with harm reduction providers. So I wanted to speak about this topic, but I think that there are a lot of false opposition that led to misunderstandings about drug consumption room. So Viktor, I will give you the floor about the models that you choose to implement in Czech Republic.
Yeah, thank you, Maria. Well, we already tackled some of them. Yeah, there were several important factors which facilitated the opening of the program as such, and the design of the program in Podane, Ruce in Brno. First, I already mentioned, this is the national situation in drug policy. I don't want to go into details, but there are currently ongoing several policy and legislative initiatives in Czech Republic, moving beyond the paradigm of punitive prohibition, more towards decriminalization and regulation. And this is also part of this initiative, especially this decriminalization, because this is the restrictive law, or restrictive and conservative interpretation of the law on the possession of substances, which was the barrier for the last 30 years in Czech Republic, right? So this is part of this decrim package. We created at the national level, we created a concept of drug consumption rooms in the Czech Republic, and we shared it. We somehow discussed it interministerially. Yeah, so this is important. This national dimension. Then its local situation in Brno city. And here I would like to mention good governance in drug policy, which is very important. So there is a good drug policy planned, informed by evidence, pragmatic. Harm reduction is part of this policy historically, I would say. So drug consumption room has become part of this city strategy. So there is a support from the city, from the district, where the drug consumption room is operating. There is a working group consisting of different departments, services in a city, including law enforcement agencies, we communicated the concept of the program well in advance with this group, and it was done in cooperation, I would say. Then it's local situation in terms of epidemiological situation or drug situation in the city, yeah, which is shaping the design of the program. So there is a specific situation in the center of the city with open drug scene or discrete open drug scene with kind of public nuisance there, with the social exclusion. It was already mentioned how important this is to tackle this as well. And it's somehow linked to the high proportion of Roma community living there, high proportion of opioids as compared with the other part of the city and the part of the Czech Republic. So specific situation. And again, it was the district government, this specific part of the city who supported very much our plans. And then it's organization, this parent organization of the program of the DCR, which is Společnost Podane Ruce, which is quite a big provider of services for drug users. The Brno city is the center of this organization. It has a capacity to start and to manage the novel program. So it is also an important factor. And then supporters in terms of financial support who made it possible, including state, city, and private, I would say, supporters. So finally, all those factors shaped the design of the program, which is mobile drug consumption room. We started negotiating this, I would say, at the end of 2021. Finally, in September 23, we opened that. It was opened as a mobile, so ambulance. You will see the pictures soon as well. So it was character of the location, lack of premises for stationary service, higher flexibility of mobile service, assumed acceptance or higher acceptance of mobile service among the neighborhood costs and existence of all, I would say, historically running outreach services, in which the drug consumption room was integrated. And so these were the factors shaping the design of DCR in Podane Ruce in Brno.
So thanks a lot, Viktor. So you highlighted very important topic, and for implementing successfully drug consumption room in local environment, the topic of alliances, cooperation at the local level, and dialogue, especially between politicians, residents, people with lived experience, and professionals is a step that is very crucial before the implementation. And I know that a lot of people who are participating to our webinar today are people from countries that have no drug consumption room now, and they will learn a lot about all the experience that all three of you share with us. So we will now move to the third question. So the third question that is more about challenges, models. So for the third question, I will ask to the panel, how has the model of drug consumption room changed since you have started? How are you adapting to changing patterns, needs, and demands? How do you envisage a continuous improvement and adaptation of the selected DCR model in the future? And the last sub-question is, which challenges or resistances have you faced in the implementation? So Viktor, I will give you the floor first for this last round of questions.
Okay, thank you again. Well, I already said that we started in September 2023. It means it has been half a year of operation of this program. Now, more or less, we did research prior the start, and it's still ongoing during the operation of the program, which contributed to the shaping of the program somehow. What was important? It's mobile. It was the decision to have it mobile was taken, I don't know, half a year before the program started. Yes, final decision to have it in a mobile ambulance, I would say. So it was there were plenty of practical difficulties to find the ambulance. We bought a second-hand one, right? How to integrate it into the existing outreach program running. The formation of the team, composition of shifts, who should participate, social workers, peers, people with medical background, emergency medical supervision, and so on. So this were the practical things we had to deal with. It started in September, 19th of September last year, with 2 hours per working day from Monday to Friday. Now, since January, it has been extended to 4 hours a day. It's operating in one spot of the city, in the center of this exposed district, exposed location, from 2 p.m. to 6 p.m. It means also, I mean, doubling the operating hours means to double the budget, right? So it's challenging, but the coverage is not the best. It's just 2 or 4 hours a day. People are using the need to use the safer space. I mean, not just for those 4 hours. So the coverage, we know that the coverage is limited and the impact is limited so far. So our questions for the future are how to increase the operation and how to sustain the program, how to ensure the sustainability, how to decrease the barriers and increase confidence of the target groups, and especially the Roma community, because the ambulance looks too official. Yeah, it's too medical. It is also based on the evaluation we did. So we are trying to integrate as much as possible to the social services in a community. And there is also a question how to provide opportunity of safer injecting to other people who inject drugs in Brno, beyond the specific location in the center. So there are plans, ideas to open drug consumption place within the drop-in center already operating in the Brno city for people who inject drugs, mainly for methamphetamine users, because this location in the center is specific for opioid injecting. Yeah, and there are more or less 2 distinct drug scenes. The one in the center with the Roma community and the opioids, and the rest of the people who inject drugs with majority of methamphetamine injecting. So how to serve the needs of methamphetamine injectors. So there are the ideas to make a small stationary within the drop-in center. And yeah, that's it. Yeah, now we simply it's too soon from the opening, so we are somehow facing the challenges and needs who are coming now, and trying to ensure the sustainability of the program. This is the most important. Thank you.
Thank you, Viktor. Yes, sustainability is very important, sometimes challenging in complex political settings. Marylin, I will give you the floor. Could you tell us a bit more about how your model has evolved and the challenges that you have to face in Germany?
Yes, of course. Like the model of the consumption room itself didn't change that much in this year. So of course, there have been adjustments, changes to the needs of our visitors. For example, like very quickly there were created more space for inhalative consumption, so for smoking. Like rethinking old rules, like what makes sense for the acceptance for our visitors. For example, like cooking crack is allowed with natron, for example, like all these little steps, like there's, always like a development, but the mainly model itself didn't change. I would say Ragazza is very flexible in changing services for the needs of their visitors. For example, like opening hours. For example, like, in the last days, it was more open in the night time. But then it was obvious that there's more need also like in the daily opening hours. So this is quite flexible. Also like very flexible in creating places to sleep or for overnighting, because also like poverty and homelessness also for our visitors is a big problem. And always check new medical treatments, etc., what we can offer for our visitors. So there is flexibility. And in all these years also Ragazza established important projects like Ragazza Mobile, Ragazza Contact, like all these outreaching projects. But as I said, like the main model of the consumption room didn't change that much. Ragazza is networked, part of the nationwide consumption room meetings, and is open to take part in model projects, like very up to date. There was this rapid fentanyl testing, the RAF project, stuff like that. So for that. So about the changes, and of course, like difficulties are so small specific projects. So they have often fear for further funding. So the finance, the security and financing is not so existing. And in addition, like the budget for the addiction support in Hamburg, it was frozen for over 10 years. So there was not like a lot of, like you can create new ideas or to develop new ideas. And the challenges. So there's still a quite big open drug scene here in Hamburg. And of course, like there's headwind from the media, from residents, politicians, etc. But like Ragazza always could in all this neighborhood work and like networking, public relations work, etc. Could always make clear that it's also like a relief for the public. So, and of course, like there have to be like developments, like substitution treatments, emergency shelters who are consumer toleranted. We need that. So there has to be a development. And also like what the big problem is now that people without access to health insurance, or people without a secure resident status, so that you cannot offer anything else than just like the basic things. So I think that would be challenges also for the future.
So thank you, Marylin. So yes, you highlighted the topics of how to work with residents when we implemented drug consumption room, and also the role of media, who sometimes give very negative representations about people who use drugs. And one of the works that is important to when we implement a drug consumption room is also to work about changing the representation. And your work is helping also for changing the representation, the work of harm reduction. So Ester, you will have the final words for the panel.
Yes, I'm agree with everything, I think, but okay, I said, no, that the different waves of harm reduction and DCRs in Barcelona, no, started providing effective responses to an epidemic overdose related to the use of injected opioids. After that, no, we implemented DCRs thinking in inhaled route and the materials that they need. After that, during the COVID, we had to think in homelessness people and how to offer a shelter adapted to this situation. And I'm agreed with Marylin and with Viktor that DCR model should be flexible, and all of us have to have the ability to adapt, no, to different forms, to different substances, to different contexts, and not to be. We don't have the final key of the game. We are playing in this game. So, and now I think we are in a moment that we are in Barcelona. We are talking about to integrate, no, drug checking in DCRs. We are talking we are detecting, no, that medicalized spices don't like to everybody, and it's okay. So, but we have to think how to do it in another way. We are in the same moment, no, in all this story that, well, the cooperation between community organizations and administration and politicians is essential, and I'm agree also, of course, that we have to think in media. We have to think in how to show harm reduction in media spaces. We don't have a good solution in this moment about the discrimination of people who use drugs, no? So it's another thing to think. But in Barcelona, or in Barcelona, our challenges now are related with a big illegal market with high potency of stimulants. I'm in the same situation as Viktor, that we have to adapt to a good cocaine, and we have to adapt to a very high purity of methamphetamine. We have a big challenge with psychosis related with methamphetamine with people who are living in the street, and it's not so easy to give a good response, and we need more resources adapted to the situation. ¿Qué más? Well, I think, no, related with drug checking, no, we are viewing that people who use drugs, who live in the street, or who use typically the DCRs, are comfortable with this service. It's democratic because people from nightlife receive these services for a lot of years, and it's the first time that they are accessing to this service in the same possibilities. And in another, no, I can think also in groups, in population groups, and maybe we have to think in young homelessness migrant people who are arriving to Spain every week or every day, and they are using, no, they are in a migrant movement crossing Europe, but they are arriving to our territory, and they are using cannabis, they are using benzos, they are using alcohol, but also they are using another kind of substances, and transcultural approach is not implemented in DCRs in my point of view. Also, we have to think in older homelessness people, no, people who started in our case using heroin, injection heroin, and now sometimes they are using heroin, but we don't have a good heroin in this moment, so they are they are moving to alcohol, and they need adapted responses. And also I don't know, but in the last 2 months, we have detected that we have to think in LGBT people who is living in the street, who are practicing chemsex, and they are in a very, very, very difficult situation when in a complex situation when they are living, when they are homeless. So that's all, I think.
So thank you so much, Esther. So some words before opening the discussion. So I would like to thank the three of you, because your speech were very inspiring, I think, for people who want to implement drug consumption rooms in their cities, in their countries, and you highlight very well in the panels that you have today how drug consumption rooms are only a part of the solution, and how if we want to have a drug consumption room to be efficient, we need to have dialogue, cooperation between all stakeholders, with the police, with the residents, with the politicians. And we also need to address stigma, social precarity, mental health problems. So a lot of things that go beyond drug policy. And that's also why we need to have a drug policy that address all these topics. So thank you so much for sharing your experience. That was, for me, that was, I learned a lot by hearing you. So thank you so much. And I will now give the floor to Marika, who will manage the discussion today. So Marika, the floor is yours.
Thank you, Marie. Excellent chairing and also exceptional timing keeping. It's very nice to see all the conversations in the chat, because the collaboration of people supporting each other experiences is something that we really value. The questions, I think most of them have been answered in the interventions. There are a couple that are of interest, I think, because the overall question is how to help the communities that are not prepared to accept this type of intervention. There is one specific about the collaboration with the police. And I remember when I visited the Barcelona experience, that there was an amazing level of collaboration. I don't know if Ester wants to start, and then possibly the others can say just a quick comment on this, how to prepare and create collaborations with the police.
Okay. I think in my experience, collaboration with the police have a lot of challenges, but we have been working for 20 years with the police. At the beginning, it was very difficult because we have two different views of the reality, and it's okay, and it in some parts have to be in this way, because we are doing very different things. But we are very close now. We are very close. We are friends, and also we work in a harm reduction mood. Everybody, when we are collaborating with police. Of course, we have a very special situation with police in Barcelona, because we have two different policies, one local, one community, one Spanish. But and sometimes in substance terms, it's difficult to understand and to work. But we have weekly meetings with the police, talking about the security, but also talking about our security, also talking about some neighbors who need some different approach to be more understand and to understand some parts of our work. But yes, it's a weekly meeting, a normal meeting in a normal space. Everybody is wearing normal clothes. It's not It's not a, I don't know. It's not like a film. It's normal. It's as other community agent.
Thank you very much. Anybody else? Marylin, Viktor, would you like to add something on this experience? Viktor, go ahead.
Yeah, if I may, we have similar situation. We have very good communication and cooperation at the local level in the city of Brno. I have mentioned police, municipality police, as well as the state police in Brno is part of this working group. Of course, there are still differences in interpretation of the drug control law in terms of the possession of the drugs, but we have prepared very well. We have done the legal analysis from our point of view, why we think it's legal, it's legitimate and legal to run the drug consumption room with the legal arguments based on jurisprudence and the legal court decisions. Yeah, so it was somehow accepted, so it's tolerated. Yeah, in this respect, also by the I would say substantial opponents of those programs with regard to the drug control law. So it's tolerated at the local level, and in this policy, I would say platform, we communicate and we cooperate. So.
Thank you very much, Marylin, and also Roberto. I don't know who of you would like to say something about this collaboration for health and security.
Before in the year 2000, where there was the legal authorization of consumption rooms, of course, like it was like this commitment of silence, you know, like that these rooms could exist. So it was quite difficult at that time, I think. But when the legalization was coming in 2000, of course, there had been a lot of actors on the table to run a consumption room, and I would say it's always like a kind of waves, you know, like it's getting good and then it's getting less good. And at the moment, I would say like we have a strong headwind at the moment since last year, and at the moment maybe it's a bit more difficult at the moment, but of course, like there are conversations, like if the chief of the police department is changing, of course, like we get to know each other and, you know, we're talking. But I would say it goes up and down like this. Yeah. But we are in a kind of, in conversation.
In a dialogue. Roberto, would you like to add something?
Just in case, I left in the chat a couple of resources on the relationship cooperation with police and drug consumption rules that may people find very helpful as a bit of a guidelines and also a bit of a study. We see that it changed radically from cases like the Netherlands, in which the police was one of the main forces that was supporting the operation and creation of drug consumption rooms, to other places in which it's really opposing. But we see that in general, as a general rule that works really good, is the creation of local roundtables that are established, in which the police actually is always being part of, in which actually the DCR, the neighbors and the police are in there, and the police can even provide evidence and backup support for the DCR, evidencing that there is no problem, so something is happening. The other part that we see is very important is the establishment of standard operating procedures, because it is also very clear to understand what are the boundaries of the relationship between the drug consumption and room, because there is moments in which police can be incredibly supportive of the labor of a drug consumption room, but in another times actually could be creating an increasing vulnerability of the people that is coming. So establishing these two things works. And the last one is training, education, support, and the change of the paradigm, engaging with the police, having conversations. Within the police department, sometimes we tend to speak of police in a very general term, but there is policemen that they are very much close to the work that is done. And already some policemen within the police is the one that can be doing the advocacy within the police. So sometimes looking into concrete people and how to establish these smaller bridges can be very, very helpful and support with education.
Thank you very much. This is very, very helpful. Marie, would you like to add something? I'm insisting on this question because I think it's a very important question. It talks about the role of the entire community to support all the social problems we are observing. Marie?
Yes, I totally agree with you, Marika. Working in cooperation with police is also a key also for the success. I can speak very briefly about two experience, also French experience, because I'm French, and working on the evaluation of French drug consumption rooms. In Paris, for example, the chief of the police in the district are very supportive to drug consumption rooms, and because they see that drug consumption rooms are effective. So I think that's very important. Another time, I insist a lot about this, to go beyond false opposition. So in media, journalists often oppose police officers and residents with harm reduction, but they give a false vision about the reality. Because I do a lot of semi-structured interviews with police officers who are working around the drug consumption rooms in Paris, for example, and they are very supportive. And some of them have a very close contact with harm reduction providers. And how they become supportive? They become supportive first because they see that drug consumption rooms are effective. And the second key of success is what Roberto just said, is a dialogue. It's very important to have a dialogue with the police and between police and harm reduction. And the other experience that I will want to share briefly with you is the Danish experience. I was in Copenhagen during the last summer, and with a French delegation of politicians. And we met the police officers from the district where the drug consumption room is implemented, one of the drug consumption room is implemented in Copenhagen. And it was a very inspiring experience, because the police officers that we met were quite harm reduction providers, because they accompany people, they meet in the street to the drug consumption room. They are very respectful, also relationship with people who use drugs. And one of the key of the good cooperation is also the training. So the training is something very important, as Roberto just highlighted this topic too. I think that when police officers have regular contact with harm reduction providers, and where they are well trained, and when they have good informations, scientific information, they can work in good cooperation with harm reduction providers and in a respectful way with people with who use drugs.
Thank you very much, Marie. I would like to call Alexis to provide some conclusion. I already can imagine a next webinar on this topic, inviting people from the police to give their also point of view. Alexis, please go ahead.
Yes, Marika, can you hear me? Yes, first, thank you all. It was very exciting, presentation. I really enjoyed to listen to all your presentation, also the questions. Difficult to bring something really new after so many useful things. I want also, before to share the few reflections, I want to say hello again to all the participants. I see people we know from many years, like Pavel Bem joining us today. Some people I've not seen for many years that I see in the list of participants. Even some good colleagues from Turkey, Peyman Atlan, for instance. The first thing I want to share with you, and especially with those who don't know DCRs, is that for me, the first keyword and the main keyword of DCRs is humanity. And it's citizenship, in the sense that 30 years ago, we even had an auto-support or self-support group of people using drugs in Belgium who called themselves citizens like others. And I think we still face the problem with the stigma. And also this idea that is even more wrong today than it was before, that there is one typical drug user, the drug user, And today, I don't mean this was true 30 years ago, but today it's even more wrong because there are so many substances, so many users, and DCRs are not necessarily the answer for all of them. It's important to highlight that DCRs and some of the other responses, they're extremely important to address those who are more vulnerable in our society. And I think what was explained by colleagues, what I've seen when I visited those programs is that our humanity is more vulnerable today than it was 10 or 20 years ago. And this interacts with the highest availability and production of drugs and any kinds of substances in Europe. And this is what calls for a renewed vision, not only of DCRs, but of harm reduction. Harm reduction is not only and will never be in the future enough to speak about needle exchange or substitution treatment. And I think we got plenty of good examples. And I usually join a special call, and I want to thank, for instance, Ester and the colleagues from Barcelona and Medicineres, of course, not only because women are always the most important, biggest group of victims, and they are frequently underrepresented among those who attend the services because the services have not been designed for them. And this is why, for instance, in Copenhagen, they decided to create a DCR that is reserved to women. I don't like to say it's only for women because when you say that, you suggest that it's not enough. So it's reserved for women. The second point is what you illustrated today, and I find it's one of the most interesting trends in the last 20 or 30 years, is that the evolution is that the starting point is a local, or should be even more in the future, a local diagnosis to identify the specific local problems and needs, including specific mixtures of substances. We had a very interesting discussion last year with the street workers in Thessaloniki, for instance, about some mix of substances involving buprenorphine that is only being done, or at that time was only taking place in Thessaloniki, nowhere else in Greece. So also it shows how relevant and important is the work of the DCRs to detect, to learn about what is the use or the most risky use today. What are the emerging substances and emerging threats? So when I mentioned the local diagnosis and local responses, it has, and we had very good examples today. The key is to make it a participative diagnosis. And when I say that, there is nothing new. There were methodologies like participative action research that were developed 30, 40 years ago. Almost everybody forgot about them, but we don't need to reinvent the wheel. We just need to update, to come back to in some cases, to come back to some of the roots of harm reduction, but to integrate harm reduction and risk reduction to the new substances and the new risk behaviors. It's important because that's the only way to design the best possible DCRs as a response to a specific problem in a specific location. And this is important because that's the key to define clear and achievable objectives. And here we have a big challenge because in some cities where there is a DCR established, there are sometimes wrong expectations. At the same time, it doesn't mean that we need to be rigid. We need to be pragmatic and feasible and flexible. And many of the new drug consumption rooms are very different from those who were established 10 years ago. And maybe in 5 years ago, we will discover that it was possible to even better articulate the work of the DCRs with treatment or even with recovery, because treatment is not only a substitution. And let's be honest, the more drugs there are, and the more drugs that are not opioids, in any case, substitution will be every time even less the solution. Problem is that we don't have any similar alternatives for the group of substances, so we need to reinforce or offer. A key point that surprisingly, you have not mentioned, but then I can at least try to say something original to finish this webinar, is that the DCRs, they are not the cause of violence, and they are not necessarily the solution to violence. And I think we need to repeat that every time, because there is also a confusion among citizens, among politicians, decision makers, who will say, but there is more violence in the city over the last 3 years, and they say this is because the drug consumption room, for instance. Well, no, it's just the fact that at the same time there was an increase on drug-related violence on the drug market, and well, it's concomitant with the moment the room maybe was open, but there is no causality. But the problem is the drug consumption room per se cannot be the perfect answer for violence. We need other response. And this is why I'm calling for a joined-up diagnosis and building new responses. We have not mentioned evaluation. I think we could come another day, another webinar on that, probably also with Marie and many other colleagues. I wanted to refer, listening to Viktor, one of the things we have been using, we are not activists, but our role is to provide the right and correct and objective information. It's the official statement from INCB, from Werner Sipp in 2016, that says clearly on behalf of INCB that DCRs are compatible with the UN conventions. So I think it's not me, it's not Marika, it's not Marie, it's not Viktor, it's the INCB. So it's not a question to invent, but just to make sure that the right information is shared with those who are not always sure if this is really compatible or not. And then finally, a last comment is, it's also about the new mandate of the new agency that we are going to launch early in July this year. You probably know, or some of you probably know, that we are transforming ourselves into the European Union Drugs Agency, and the new mission of our agency will be preparedness on drugs at EU level. And in fact, for me, and what is new also for the new agency is we will have the possibility, the responsibility to make, upon request or from our own initiative, recommendations. And the first recommendations we are planning to make in July at the moment of the launch of the new agency. And it will be about our preparedness at EU level regarding the global risk related or identified with synthetic drugs. And there, I think our call will be to mention that we need to maintain and further strengthen the treatment offer, and of course, change, adapt prevention intervention. We need to further maintain and further develop harm reduction systems. So DCRs, drug checking, but also naloxone to be ready, because we can expect that because of the ban on poppy cultivation in Afghanistan, we may see already this year the drought of heroin on the European market. And if we want to be prepared, to be ready in the case there would be a shift towards the use of more synthetic substances, among others, those substances, there can be a shift towards more synthetic opioid substances, but not only. It's not a question to wait until then to start thinking about what we will do. The new mission is about preparedness. And here, to adapt and to encourage member states to move maybe more quickly, to change the rules for naloxone, to change the guidelines, to be ready with nasal naloxone, to have the responses that will allow member states to avoid the 120,000 people dying every year in the States, for instance. That's now that we need to prepare. And finally, I think what is very important is to highlight what Ester or Viktor and others have mentioned, is the fact that we need to go back to more inclusive and social inclusion policies. There is nothing that can be achieved only with one kind of response. and I think for me it's the biggest challenges maybe, is that we have such a fragmentation in the society, a fragmentation in the policies, in the programs, and in the funding, that at the end of the day, we are losing not only what is the possible cement between the interventions, but the cement between the citizens in our society. And for all of that, I want to thank you really from the deepest of my heart for the work you are doing, for those challenges, for the courage. Every time I visit the people working in the DCRs, I think you need to be very courageous and resilient mentally to work in difficult conditions with people who use in sometimes very difficult conditions. You need to try to save people from overdose. You need also to convince the decision makers to finance those programs. And you have people who see that all the day long, and there is no way for them to see another behavior among their clients or their patients. So everybody is extremely resilient. And I think the challenge for us, if we want really to go towards EU preparedness on drugs, is to support more and better those efforts, and also to articulate them with all the other interventions, some of them not yet existing, but that we will need in the future. Thank you very much.
Thank you, Alexis. You are receiving a lot of thank yous in our chat, as well as all the other speakers. And thank you very much, everyone. Send us, I'm talking to our audience, send us proposals for webinars, because you are such an interested participation group that we need to have your ideas to keep our program always at the high standard. Thank you, everybody. You can go. I will launch a poll, but you don't need to remain. It's just for our audience to express their preferences. Thank you, everybody.
Thank you. Bye.